Hi,
everyone. I'm Jack Cush with RheumNow. This is the podcast. This week, a special podcast, an interview with Dr. Ed Keystone on the 60-40-20 response seen in all the clinical trials. We're going to talk about the origins. Ed is a professor emeritus at the University of Toronto and one of my best friends and one of the people I miss during the pandemic because Ed and I on the road, it's nothing but fun. Ed, how are you?
I'm very well, thank you. I'm living the life.
Oh, there you go. And he just told me Toronto is the Florida of Canada. So they don't have snow yet. He's very, very happy. That's why he's smiling. So Ed, I want to talk about 60-40-20, but I want to tell a vignette that gets me into this. And that is probably 10 years ago, 12 years ago, we're at EULAR in Paris. You're up on stage giving like one of the plenary session talks. I think it was about certolizumab. And I remember you telling me that you had practiced this thing over and over and over with multiple people, the company and whatever. And it was a big audience, like a few thousand people. And you're up there and you give your intro, you're on your second slide and boom, the projector goes out. And, everyone looks around, a little discombobulated. It's taken a little too long. You only have 15 minutes here. You got to get through the data. And you say, well, let me just go on. And, at this point, you're at the materials and methods, and you're just going to go on and do the lecture while they're fixing the projector. And he goes on and he has this thing memorized. So there's no notes or anything. And he gives them, how many patients, the design, the drugs, the doses and whatever. Now he's got to get into the results where he needs the slides to show, the histograms and the plots and the tables, and he doesn't have them. And so what does he do? He starts to pantomime the whole thing. He starts getting to the ACR 20, 50, 70 responses, and he starts doing it like, the placebo response was here, and then the ACR 20 was up here, and he starts basically mimicking the slides, and the audience is going crazy. And of course, right at the very end, the slides came back on. And of course, the funny thing that didn't happen but could have happened was that who always asked the first question? Roy Fleischman, right? And Roy said, if those darn slides had not come back on, I was going to get up there and say, Ed, on slide 6, you showed that he's going to fault you for your pantomime. That was what do you remember about that?
I remember that exactly. I don't know whether it was what country it was in, and it was more than 10 years ago. It might have been close to even 20 years ago.
Maybe.
But the point is, I heard a bang, which means there was some power problem and the screen went dead. And I said, holy shite, I've got to do something here. So I said, okay, I know the slide. So I said, look, here's the first slide, blah, blah, blah. And this is in green, and this so-and-so, and this is so-and-so. And the next slide, you'll notice is blue here and red here. And these are the graphs. And I went through all of them. And actually, it was about 10 slides into it when it was back on again. So I had a good time. I had no problem. I was calm, cool, collected, and said, well, listen, when you study at that time, and I don't do that anymore as much as I did those days, I knew it cold.
Absolutely.
And I was really glad that I was able to do that.
And what I remember, you really did know it cold, and you really did say, all right, my second slide, my third slide, you named the slide, you said what the slide was about, you painted the picture. Again, the audience was like besides themselves because they were getting it and you didn't have any slides. It was so cool. But what it was about reporting the clinical trial. And of course, the standard and the primary endpoint, and this was an ACR 20. And, that's been the standard for so long, ACR 20, ACR 50, ACR 70 being secondary responses. But, when we were out there, on the road doing stand-up rheumatology and lecturing and whatnot, you were the guy that came up with this idea. The ACR 20-50 response is always 60-40-20. How did you come up with that?
Well, in about 2004, I decided to read the literature. and I said, and I started to look at a few of the studies back then. And after looking at 3 studies, the ACR 20 was 60 in these different studies with different biologics. The ACR, the ACR 50 was 40 and the ACR 70 was 20. So I looked a little longer at those, and it said 60, 40, 20. And then when you had a TNF failure, that was methotrexate inadequate responder. When you had a TNF failure, it was 50, 25, 12. So I had the 60, 40, 20 and the 50, 25, 12. And I kept using that all along. And what's even interesting is when you look at the data from psoriatic arthritis, ACR 20, 50, 70 is 60, 40, 20. When you look at ankylosing spondylitis, the ASAS, it's 60, 40, 20. I mean, it's unbelievable.
I'll
I
tell
mean,
you,
that's what I find.
Yeah, and the interesting thing about the ACR 20, a tool developed for RA being applied to psoriatic arthritis. I remember Lee Simon, who became a director at the FDA, was he was against the idea of using the ACR 20 because it wasn't developed for psoriatic arthritis. And that's what Jeff Siegel and his team did at the FDA. But then when Lee got into the FDA and saw that when you applied it to psoriatic arthritis, it was just as good, if not even better, with better separation between placebo and the ACR 20 response. So it's been incredibly durable, but this idea of a response that is so reproducible in methotrexate IR patients, do you think it's because there's a ceiling to the measure? Or is this the best we're ever going to do in RA?
You know, I've asked myself that question for 20 years now, and I don't have the answer. But we see ceiling effects everywhere, right? Not just in RA, not just ACR 20, 50, 70. And I can only say that that ceiling effect is not just the ceiling, because when you look at JAKs, you look at upadacitinib, it's not 60, 40, 20, it's 75, 45, 25. If you look at baricitinib, the 4 milligrams, we don't have it because we're afraid of it, so we use it too, but the 4 milligrams was also the 70, 50, 30. So the ceiling is not 60, 40, 20. It depends on what drug it is, and the new therapeutics are better than 60, 40, 20.
Yeah, and certainly that happens in psoriasis. They had their ceiling effect with a PASI 75 response and that's when they were using all the drugs up to TNF inhibitors. But then once they got into IL-17 and IL-23 and whatnot, then now they're measuring PASI 90s, PASI 100s, and so I think that there isn't a ceiling effect, and it is about getting better drugs, better trials, maybe better patients.
Right, that's what's happening.
Yeah.
It's clear. When I saw the data from the JAKs that were no longer 60, 40, 20, everybody said the 60, 40, 20 is dead. But what's interesting is, very interesting, if you look at the JAKs at 12 weeks instead of 24 weeks, it's 60, 40, 20. And when you look at the ACR 20, 50, 70 of 50, 25, 12 also occurs within the JAK spectrum, but it isn't the same as using biologics, but it's still there, the 50, 25, 12 post TNF, but where is it? It's at 12 weeks instead of 24 weeks. And the 60, 40, 20 is now at 12 weeks instead of 24 weeks with the JAKs. So it's amazing. The numbers, and I mean, I don't know, there must be a God. That's what I said when I saw the data. There must be a God, because all those numbers, 60, 40, 20, 50, 25, 12, still exist, but they moved them from 24 to 12 weeks.
I want to remind the audience of the origins of the ACR 20. Before there was ACR 20, the cooperating clinics led by Ward and all those people, they looked for a measure that would show a true difference between a drug response and a placebo response. And they came up with the Paulus 50, right?
Yes.
And then the Paulus 50, which had the same 7 core set variables, ultimately became the ACR 20. And it really is a measure designed to show a difference between a true drug response and an efficacious response and a placebo response. Do you still think it indicates that?
Yeah, I still do. I mean, and how do I know that? Because obviously I look at the indices within the ACR 20, 50, 70, the swollen joint, tender joint, the issue of patient-derived outcomes, even x-rays initially was part of the ACR 20, 50, 70. So I think the elements still show a difference never mind the 20, it shows a difference between, the top line and the bottom line, and all of the other elements are generally, but not always, related. And the other problem is the patient-derived outcomes. And if to get remission, you need more than one of this, more than one of that. And you didn't make a remission because the patient-derived outcomes did not necessarily match the less than -1. So I can say that, yes, there's relationships, but those relationships aren't always what you might have expected.
So I'm going to ask you for quick hit answers on AC. What do you prefer, ACR 20 over these alternatives? Patient-reported outcomes.
I hate to say ACR 20, 50, 70, period.
Okay.
Patient-derived outcomes are fine, but they don't match necessarily the biologic response.
What about rapid 3? All things that the doctor doesn't have
That's
to
all
measure.
patient-derived,
Yeah.
and there's general correlations. But in fact, and I think the rapid theory is great if you don't know how to do a joint count, which may be seen not infrequently.
Right.
So yeah, I think relationships exist, but they're not as close or as easy as each one.
What about the holy grail of science, a biomarker?
Which one?
A biomarker. I won't say which one. I don't think a good one exists.
Well, the biomarkers just haven't made it yet. They've tried very hard. Genetics is working on it, and there's new data from genetics now that is closer than it's ever been in terms of predicting who's going to respond or not. And that's recent data that I've seen, and it says we're getting closer. But a few years ago, when they asked me to give a lecture on the genetics and all of these biomarkers, the answer is I could not say that they were efficient, effective enough to actually say yes or no. They are getting there.
So the ACR 20 is a great tool. Ted Pincus said a long time ago, we were at a meeting in Portugal. I know you were there because we took the flight over together, but Ted got up and said something like, we are failing as clinical trialists when we choose a measure that does not approximate practice. So we don't do ACR 20 really in practice. These disease activity measures, of which there are many out there, CDI, SDI, even rapid 3, my gas score. Do you think we should be adopting those as our primary endpoints in clinical trials with the hope that they also get used more in practice?
I think CDI particular, where you don't need a SED rate, for example, and I think they're much better. They're anything that's easy is what we should be using.
Right.
And these are easy. They're mathematical. You add them together. You
Right.
don't do a square root. So the answer is yes. I definitely believe that the CDI particularly easy to do. Don't need a SED rate. Just do a little bit of math, depending what grade you got to.
Well, I'm limited by my fingers anyway, so it doesn't
I
really
know.
matter.
Well, if you got to the appropriate grade to add, then those actually work, and they work well.
Yeah. The one thing that concerns me about the measures we use and some of the trials is the placebo rate's gone up a little bit.
Yes, it
It's
has.
actually gone up a lot. I remember, back when psoriatic arthritis trials were rolling out, they had single-digit placebo responses.
Right.
We had, early days of RA, we had 10 to 20% placebo responses. Now it's not uncommon to see 35 and 40% placebo responses, and you're going to have to go with the treatment effect, the delta.
That's right.
What's your take on that?
Well, first of all, I think that the placebo rates are going up because people are more interested and enthusiastic about the various therapeutics. And of course, if you're enthusiastic, the numbers go up. So it is an issue. And I think the delta, I think the effect size is going to become important, is becoming more important. In fact, you at least have to look at the effect size or the delta between the two, not just the results. So I think you need both. I think it's okay to have the ACR 20, 50, 70, but I think a delta is important. And if the delta is less on methotrexate inadequate responder, less than 25 or less than 20, you have a problem, because then you know that there's an issue in terms of the efficacy because the placebo is too high. So, and notice that in TNF inhibitors, TNF failures, those deltas, that is, those placebos are lower. Certainly post-methotrexate, they're now 30, 35. When you now look at the TNF-IRs, they're not as high. And then you can see at least a relationship, better relationship.
Yeah, so I like that you're saying just don't look at that top number, that ACR 20. The delta is important. What do you think? In this last ACR, a lot of discussion about the oral surveillance study, very large and whatnot, and the safety signals were really a little scary, but not so scary if you consider the number needed to harm, where the numbers needed to harm were anywhere from 250 to 700 if you look at BTE.
Right.
Similarly, you could look at clinical trial data and come up with numbers needed to treat or get better.
Right.
Do you think about those at all? Do you think those are important?
Well, I think about them, but the problem is I've tried to teach them to my colleagues and they're confused. They have a problem handling that type of data. So the companies were all very keen to use this, and I thought I was great. And then when I had meetings with my community rheumatologists, they really didn't understand it and they didn't want to see it. They knew the numbers that we had. They didn't want to do numbers needed to treat because it was a whole new vocabulary for them.
Yeah.
And they didn't have what we have now, the 60, 40, 20. You can look back 20 years, at least you know where you stand. As soon as you add these numbers, and I don't disagree using them, but there isn't enough data out there to put it in context.
So Jeff Curtis and I did a survey of many rheumatologists when I was doing all the surveys, and we came up with a number about 54% of rheumatologists measure something, a hack, a CDI, a rapid 3, whatever. The most common thing measured as a true outcome measure was rapid 3 at about 30%. And then things like CDI at about 12 or 14%. Unfortunately, vector at around, I think, 12% as well. Do you think docs are measuring more? Do you think docs are practicing treat to target? In fact, I mean, you can measure, but that doesn't mean you're truly treat to target. What's your opinion?
My opinion is that you don't necessarily treat the target. And yes, they may measure, but we are getting better because when you're looking at some of the real world data, that real world data does suggest that they're actually treating to a target. And so that's improving. I think that the issue of achieving remission or low disease state is improving because people are thinking about it, but I'm still concerned whether, and it depends on measurement. I mean, if you don't do tender and swollen joint counts and you decide and use the patient-derived outcomes, there may be issues. If you're tired, if you're fatigued, if you have back pain, all of those increase the patient-derived outcomes or alter them.
Right.
And that means it's not the thing I worry about most is the biology versus the emotional aspects of things. And I'm concerned that I know the FDA says, oh, we got to look at more at patient-derived outcomes, but it doesn't always match the biology. And that's my concern.
All right. I want to close with where you think we're going as far as outcome assessments in RA and particularly clinical trials. Do you see it changing, especially as maybe clinical trial designs may change going forward? Where do you think we might be going?
Well, again, I think the important thing is that people are now thinking about treat to target. I think people aren't doing, they're not doing a tender and swollen joint count. And if they don't do counts, then they're going to need patient-derived outcomes. I think patient-derived outcomes are becoming a bigger element in how we think about patients. And in fact, in some ways, it's not bad. I mean, think about patient-derived outcomes. At least you're looking at the patient there and understanding the patient elements. The only thing I say is when I'm doing, an assessment, and then you have this chart, tired, fatigued, sleepy, blah, blah, blah. And then you can tick off. And I think there has to be more, if you're going to do patient-derived outcomes, you can't just say, how are you feeling today? You've got to check off in a religious way exactly what the elements are that are contributing to the patient-derived outcomes, because it may be fatigue, you can't change it, but you have to understand why it's there. So I like the idea of doing patient-derived outcomes. I just think you have to be more specific about what those outcomes are.
Interestingly, the EMA and the FDA, I think, are considering incorporation in drug development of real world data, RWE trials. And so these, everything you just covered is going to be fall under that umbrella, and meaning that they're going to be more impactful and substantial. So,
Yes.
So Ed, today is Thanksgiving in the United States. It's a holiday we celebrate for when we invaded the shores of America and took the food away from
defeat the Canadians. Yeah, you tried, I know.
Yeah. So why do Canadians have Thanksgiving on a different day?
Don't ask. I have no idea.
Oh, so you are the perfect. So I have a series of Canadian holidays that I know nothing about. I'm going to mention them and give you my interpretation, and then you'll tell me what they really mean. And so Canada Day is the day that maple syrup was discovered, is what I would think. What do you think?
Well, I think Canada Day was actually to reflect the Canada as a nation in the date that we were eventually declared to be a nation.
Yeah, I think the maple syrup holds better for me. Easter Monday, I don't get that at all. You take a day off after Easter. Is that a hangover issue?
I don't know. I'm Jewish.
Well, speaking of that, National Day of Truth and Reconciliation. That sounds like a Jewish holiday.
No, it's definitely not a Jewish holiday, and it's very important. It's really one of the major things that we think about now, particularly when we found all of these graves of the individuals, the First Nations people who are actually died in those homes in the schools without anybody talking about it.
Yeah. So now I feel bad bringing this up, but I'm still going to go through with this. Boxing Day, I'm thinking that it's like your version of Christmas or something, and it's all about presents, and you couldn't call it Present Day, so you call it Boxing Day. What do you think?
Yeah, that may be the case. It's a holiday. It's a marketing holiday, is all I can say. A marketing holiday, and you want to sell more, and you want to give back the stuff you don't like, and so that's where it is.
And Victoria Day, it sounds like continued infatuation with the Queen.
Yes, we are infatuated with the Queen, and it's Victoria Day. It was the birthday of the Queen years ago, and it's an important holiday for us because we still feel connected to the monarchy. Don't ask me why, but we're connected.
Yeah, and we're connected, but in a spiteful way, and that maybe is a lot of the American personality.
Well, no, but I remember, I mean, it was the British who gave the Americans a really hard time, and they controlled it. And the Americans said, enough, we don't want this anymore. So they threw the tea overboard. And, it's interesting because America is based on a military success. These things are based on a military success, and therefore the military becomes very important in terms of your concept aside. Yet you can carry a gun, that amendment.
Especially in Texas. Yep.
Yes.
So Ed clearly knows more about American history than I do, but then I clearly know more about the Canadian pastime hockey than he does. This is why we're such good friends. Ed,
yes.
Thank you for being with us, and always have many great holidays ahead.
Thanks very much. It really is lovely to talk to you once again, my friend.
All
Take
forever.
care. Bye.